Hi friends, so now we begin the discussion of musculoskeletal radiology. This is a topic which will have a lot of overlap with orthopedics, so there are going to be a lot of things that you will also learn in ortho. What I have done is I've tried to integrate everything you need to know from orthopedics as well as from pathology as far as bone tumors are concerned, and then we'll be talking about metabolic bone diseases, we'll be talking about arthritis, which have a lot of overlap with peds and medicine as well. All right, so we'll be studying this in an integrated approach. That is how you should also do it. Once you're done with this lecture, just quickly go and revise orthopedics rapid revision. Also go and revise the bone tumor section of path and arthritis and rheumat as such from medicine. That will be very useful in bringing everything together. Okay, so let's begin then with the very first topic, that's gonna be the thumb rules. So here I just want to give you an orientation to what are all the investigations that we use in orthopedics or in bony pathologies in general, and this will help you a lot as far as building your concept is concerned in what investigations we are going to do throughout this topic. Okay, so the initial investigation in anything related to bones, remember, we will be doing an x-ray. Okay, so if you have ever gone to your ortho postings, you would have realized that x-ray is must. All right, it's one of the most routinely ordered investigations as far as the bony pathologies go, and that is always the first investigation. What is the best investigation? Now, depending on what pathology we are dealing with, what is the compartment of the bone that we are dealing with, we have various concepts here. So whenever we want to see cortex or cortical pathology in general, remember C for CT. It's going to be CT scan, which is the best. For example, if I want to see fracture, which is nothing but a cortical breach, we'll go for a CT scan. If I want to look at an osteoid osteoma, again, osteoid osteoma, remember, is one of the rare bone tumors which is cortical based, okay, which is only cortical based. So when I want to look at an osteoid osteoma, it's going to be a CT scan, which is the best. But remember, for all other bone tumors, it's going to be MRI. Okay, so what we've learned here is because osteoid osteoma is cortical based, it's the only tumor where investigation of choice is going to be a CT scan. Everywhere else, for all other bone tumors, our investigation of choice is going to be MRI, because MRI can show you marrow involvement, as we'll discuss. It can show you the neurovascular involvement. So MRI overall is better, exception being osteoid osteoma. Then talking about calcification, we know this thumb rule. Anywhere we want to look at calcium, whether it's bony, soft tissue or intracranial, answer is always going to be a CT scan. There's no two ways, there's no exception to that rule. Okay, now talking about fracture again, so I did mention fracture because it's a cortical breach, it's going to be CT. But one thing you want to remember here is that the exception is stress fracture. Now, stress fracture is something wherein you will not always see a cortical breach. So that is why for stress fracture, where I mainly rely on the bone marrow edema and not the cortical breach, answer becomes MRI. Okay, so that also tells me that for bone marrow per se, the investigation of choice is always going to be MRI, whether it's for looking at bone marrow edema in a stress fracture, or it is looking at acute osteomyelitis, which is earliest going to present with bone marrow edema, or say sacroiliitis for that matter. It is always going to be MRI, which is the best for bone marrow edema. Then looking at cartilage, again, CT cannot show cartilage. So remember, all C's, that is cortex, calcification, CT, but for cartilage, we need to do MRI. Alright, so for cartilage, we have MRI. One very important example here is osteochondroma. So we'll be talking about bone tumors. I'm just giving you a brief capsule right now. So osteochondroma is a bone tumor which has a cartilage cap, and for that we need MRI. Okay. Then soft tissues, again, MRI has the maximum soft tissue resolution, so MRI is the best. So are ligaments best visualized on MRI because the soft tissue components not seen on CT. So for all ligamentous tears, we will always do MRI. So remember an important topic of orthopedics, that it's sports injuries. We wholly depend on MRI. And if they ask you what is the gold standard for ligaments, then it becomes arthroscopy because it is diagnostic as well as therapeutic. Okay, so this is your thumb rules here, just to give you an overview. Anytime we're talking about cortex calcification, best is CT scan, and anything else that is bone marrow, cartilage, ligaments, soft tissue, we are going to rely on MRI. Okay, so this in a nutshell takes care of the concepts as far as investigations are concerned. Now we're going to go topic wise. So the first thing that we want to discuss is bone tumors. Okay, so in bone tumors, we need to adopt a very systemic approach. It's a very common instinct to just jump to the diagnosis the moment you see the X-ray. As far as MCQs are concerned, to a certain extent, you can do that, but in practice, you can never ever do that. You have to take into account each of the points, which I'm going to highlight on this slide for you. So we have the location, we have the age, and we need to remember certain points to distinguish whether we're dealing with a benign lesion or a malignant lesion. Okay, so now the most important, again from MCQ point of view also, location is one of the most important things which will help you in narrowing down your differentials. So when I say location, there are three main parts. We want to see in the longitudinal plane of the bone, whether it's in the epiphysis, it's in the metaphysis, or it's in the shaft, which is the diaphysis. So now epiphysis would be the end of the bone, right? So you want to see whether the bone tumor is reaching up to the end of the bone, it's reaching the joint surface or not. Growth plate may or may not be fused. If it's not fused, the part which is distal to the growth plate here is the metaphysis. If it is fused, then you get an approximate idea if the epiphysis, that is the end of the bone, is paired or not. Okay, so in this case, this is the metaphysis, and the shaft of the bone, the vertical part of it, is the diaphysis. So this is what you have to see where the bone tumor is. So now how do we narrow down the differentials? So here you want to remember, if it is in the epiphysis, remember a mnemonic ECG. So what does ECG stand for? So when it's an epiphyseal tumor, C for chondroblastoma. So one differential is going to be, it's either a chondroblastoma or G for a giant cell tumor. A giant cell tumor is also called as an osteoclastoma. Okay, so it's also called as an osteoclastoma. So there are two DDs when it's an epiphyseal tumor, C for chondroblastoma, G for GCT. Okay, so that is ECG for us. Then when it's a diaphyseal tumors, remember a mnemonic that vowels stick together. Alright, so there are three lesions with vowels which arise from the diaphysis. One most important is the malignant tumor, that is Ewing sarcoma. Then you have a very benign lesion, osteoid osteoma. And then one rare one that you want to remember that involves the tibia is adamantinoma. Okay, so three lesions with vowel in the diaphysis: Ewing sarcoma, osteoid osteoma, adamantinoma. Anything else is in the metaphysis. Alright, so in the metaphysis, most prominently what you want to remember here is osteosarcoma. When I remember the bony cyst, so a simple bone cyst and an aneurysmal bone cyst will be in the metaphysis. Okay, apart from that, fibrous dysplasia is also typically in the metaphysis. So you don't remember this. You remember ECG, you remember vowels stick together, anything else is in the metaphysis. Okay, so this is as far as the approach, as far as location is concerned, you will narrow down. Now, using the age, you will further narrow down which of these differentials is the actual diagnosis. So, remember all of these in the first box: a simple bone cyst, osteochondroma, chondroblastoma, Ewing sarcoma, osteosarcoma. So, from the benign lesions, SBC, chondroblastoma more specifically, ES and OS. These are all tumors that are seen in first and second decade. So, you'll be a child less than 20 years of age. Aneurysmal bone cyst, a giant cell tumor, osteoid osteoma, and FD. Now remember, osteoid osteoma and FD can be seen in any age, but GCT, very important, is something that is most commonly seen around 30 to 50 years of age. So whenever you get a middle-aged person, always remember that GCT is the most likely possibility. And then in elderly patients around 50 years and greater, you want to consider metastasis, multiple myeloma, chondrosarcoma, and if it's an osteosarcoma, it's usually the secondary variant, which is secondary to radiotherapy or maybe Paget's disease, right? So that is your secondary OS in the elderly group, most importantly, primary bone tumor, remember chondrosarcoma. Okay, so this is how we narrow down with respect to the age. So to give you an example, if I have an epiphyseal tumor, if I see that the patient's age is less than 20 years, it is chondroblastoma. If it's more than 20 years, it is GCT, right? So apart from the morphology, these are going to be very, very useful to us. Now talking about how do I decide whether it's a benign or a malignant lesion? What are the clues on the X-ray which are going to help me figure out? So here, the first point we take into consideration is the type of bony destruction. How is the lysis by the bone? When I say lysis, I mean the destruction. Normally, the bone is white. Anytime there's a tumor in the bone, there's going to be this lucency. The bone will no longer appear white. So then how is this pattern? If the pattern is very well defined, it's a very well defined lytic lesion within the bone, we call that as a geographical lytic lesion, and that suggests a benign nature of the bone tumor. If I see that there are these small lytic lesions as if there's a moth-eaten appearance, that again suggests something wherein you have a more aggressive bone tumor. Alright, so this moth-eaten pattern suggests that it's a more aggressive tumor. And finally, when you can't really make out, the destruction is so permeative into the bone that you can't make out what's the normal bone and what's the tumor, and that implies that the tumor is likely to be more aggressive, likely to be more malignant. So there are three patterns. Let me just show you the images. So in the first one, you can see how there is this lytic lesion which is having a very, very well-defined margin. So this is a geographical lytic lesion. That is how we are going to describe it. This is something which is suggesting a benign nature. When you see that there are these lytic, small foci, this is called as the moth-eaten pattern. And when you see how it's permeating, it's very, very ill-defined. This is something which suggests that the tumor is more likely to be aggressive, more likely to be malignant. Okay, so these are three patterns of destruction. The next feature that we can look at is the zone of transition. By zone of transition, what I mean is, if this is the tumor and this is the normal bone, how is the margin? If the margin is very sharp, or if the margin is very well defined, meaning it is a benign tumor. But if the margins are very ill defined, or the other way of describing it is a wide zone of transition, it is likely to be more malignant. Okay, so well defined or sharp is benign, ill defined or wide is malignant. Again, pretty logical, right? Then obviously, if there is soft tissue which is present, it is more likely to be a malignant lesion. Then comes the periosteal reaction. So now periosteal reaction means if there is a tumor which is within the bone, how does the periosteum react to it? There's always going to be some sort of behavior from the periosteum. Depending on whether it's benign or malignant, we have different patterns here. Okay, so when you see that the periosteum, let's say this is the bone, if the periosteum is forming this very solid sort of a periosteal reaction, it is just this thickening of the periosteum. This is called as a solid periosteal reaction. This is something which is seen in benign. But when you see, let's say this is the bone, and you see that there are so many lamellae of the periosteum, this is called as a multilamellated appearance, also called as an onion skin appearance. This is something which is more likely in a malignant lesion. People think this is in Ewing sarcoma alone, but no. Remember, any malignant tumor can elicit this sort of a periosteal reaction, which is multilamellae or an onion skin periosteal reaction. A lot of times what you can have is that the periosteum can be lifted. If this is the bone tumor, the periosteum can be lifted off like a triangle, which is called as the Codman's triangle. Again, that suggests malignant. People think it is only osteosarcoma which show it, but no, it can be seen in any malignant lesion. So what we have learned here is onion skin, Codmans are not just specific to Ewing's and osteosarcoma respectively, but they can be seen in any malignant lesion. Alright, so this is how we approach in a nutshell any bone tumor. You look at the location, whether it is epiphysis, metaphysis, diaphysis, look at the age, and then look at these features, whether it is a benign lesion or a malignant lesion on the basis of type of destruction, zone of transition, whether soft tissue is there or not, and whether the periosteal reaction is benign or malignant. Okay. So now going ahead and looking at individual tumors. So now what I'm going to teach you are these individual tumors. I'll tell you the salient features and we'll also do a rad path integration right here so that it's more integrated and comfortable for you to revise. Okay. So the first tumor. So we're starting off with epiphyseal tumors. Remember ECG, epiphyseal, either chondroblastoma or giant cell tumor. So now in this case what I visualize is that there is a tumor reaching the joint space. So this is epiphyseal. Now look at this. Even if I don't have the age, can I guess whether it's a child or an adult? So it is yes. Look at his growth plate. It is not fused, right? So when I say that the growth plate is not fused, I can say that it's definitely somebody who's lesser than 20 years of age. So this is very unlikely to be a GCT. It's more likely to be a chondroblastoma. Okay, so this is how you can approach even without the age being mentioned in the question. Okay, so remember, if growth plate is fused, epiphyseal tumor likely to be GCT. Growth plate is not fused, epiphyseal tumor likely to be chondroblastoma. Chondroblastoma is a very benign lesion, and remember, it is epiphyseal. The age group that it involves less than 20 years. On histopath, what we are going to see is this chicken wire calcification. Can you see this? There's calcification in the periphery. So this is chicken wire calcification on histopath that we are going to observe. One more point that you want to remember is that chondroblastoma is also called as the Codman's tumor. Don't confuse it with the Codman's triangle. That is in osteosarcoma, but chondroblastoma is also called as the Codman's tumor. Alright, so this is about chondroblastoma. Now, we look at an epiphyseal tumor reaching the joint surface and we see growth plate is fused. In addition, very, very helpful. This is one of the most frequently asked questions. We are seeing here that there is a soap bubble matrix and it's involving the distal end of radius. When all of these points come together, it's very, very likely that you are being asked a GCT question. All right. So this is something that's been given to you as a gift in the question if this gets asked. Very, very frequently asked question. Don't get this wrong. So how do we approach it? Giant cell tumor, we know it is epiphyseal, right? So one, it is epiphyseal. Second, the age, it's going to be more than 30 years. So somewhere around 30 to 50 years would be the age of the patient and the growth plate is fused. Second, distal end of radius is a very specific site for involvement. So whenever you see that, again, you have very high pretest odds of this being giant cell tumor. So one is distal end of radius, and then look at the shape here. This is a soap bubble appearance of the matrix when you have so many septations and locules here. Okay. Now, one thing is, you know it's GCT, but then you don't see it in the options. So sometimes they can also call it osteoclastoma. It's very important you know this because then you would not see GCT in the option, but you would see osteoclastoma and then you don't want to get it wrong because of that. Okay. So remember, giant cell tumor is also called as an osteoclastoma. Now, as far as the histopath appearance is concerned, we're going to have giant cells as the name suggests. So look at this appearance. You can see how there are so many giant cells, but in addition, can you see how there are so many mononuclear cells? So histopath is going to show you giant cells as well as mononuclear cells. They say that the aggressive nature, remember GCT is a locally aggressive tumor, meaning it can cause cortical erosion, but it rarely metastasizes. So it can cause cortical erosion, a feature that is more likely in malignant tumors. So that's why we call it locally aggressive, meaning it has local features of malignancy, but it never metastasizes. Okay. So that is why we call it local aggressive, and the feature, it's not the giant cells which make it locally aggressive or malignant, it's actually the mononuclear cells. So you want to remember it's M for M. So it's the mononuclear cells which are basically going to be contributing to the malignancy within the GCT, okay, or the locally aggressive nature of the GCT. And this is a repeat question, okay. Logically you would think it's GCT, it's giant cells which are going to be contributing, but no, right, it's going to be the mononuclear cells. Fine. So this is about two epiphyseal tumors. Now we discuss the three diaphyseal tumors. What are the DDs? Osteoid osteoma, Ewing sarcoma, adamantinoma. Three vowels sticking together. The first tumor that we are seeing here, we can see it's a small tumor in the diaphysis. All I see is some sort of solid periosteal thickening, and there is a cortical based very small tumor. It is better visualized on CT here. On CT, you can see how the cortex is thickened, and within the cortex, can you see there's this lesion here with a nidus. This lucent area here, this black area here is what is called as the nidus. We also talked about nidus in AV malformation. If you remember in neuroradiology, we talked about AV malformation which has nidus. This is another area where you have this nidus, and the tumor I'm talking about is osteoid osteoma. How the presentation is going to be here is very typical. So here the history that would be provided to you is there is a person who's having nocturnal pain, severe pain in the night that is relieved on NSAIDs. Alright, so this is a pain that is relieved on NSAIDs. So why such a typical history? There's a very typical history because this nidus that we talked about within the osteoid osteoma produces prostaglandin E2. How to remember? Not any other prostaglandin. It's pain. So you want to remember E. We go E when we have pain. So that's how you remember. It's E2. Alright. So PGE2 is being released by the nidus, and these NSAIDs are going to block that, and that is why the pain is relieved. Okay. So that is an osteoid osteoma. It can present in any age group. It could be a young patient or an elderly patient. So that would not help you out here. So what is going to help you is the typical clinical feature. Now, what is the investigation of choice? As we discussed, so here our main diagnostic feature is going to be this cortical thickening and the presence of this nidus, and that is why CT shows us cortex the best. So here investigation of choice is a CT scan. What about the treatment? The treatment here is also unique, wherein all I gotta do is ablate this nidus. That's the one which is causing problems. It's a benign tumor. So all I gotta do is ablate this nidus. So what we do is RFA of the osteoid osteoma. So this is radio frequency ablation, and this is what we do under CT guidance. So this is CT guided RFA of the nidus, which is the treatment of choice for osteoid osteoma. Okay, so this is about the first diaphyseal tumor. The most important second diaphyseal tumor, here you would have history of a child who's less than 20 years, who's presenting with a very large mass. Look at the soft tissue swelling. It's a very large mass. And here, contradictory to what you would expect, the child or the mother of the child is going to present to you with pain, fever, inflammatory features. There's going to be redness over the mass. So you're going to be suspecting that there's maybe some sort of inflammatory pathology like an osteomyelitis which is going on. But when you look at the X-ray, you realize it's a tumor. So this is a tumor that mimics inflammation. So it mimics inflammation because of the overlying inflammatory features, wherein there's going to be redness, there's going to be fever, there's going to be this large swelling, alright, which rises very acutely. So it definitely mimics inflammation. Okay, so that's something that you want to keep in mind. When we do the X-ray, you have this large soft tissue component, you have a diaphyseal, very permeative tumor. You can't really make out where normal bone is, where tumor is, but you also see this interrupted sort of a periosteal reaction, right? You have this onion skin which is interrupted, which is never a good sign. So this is the onion skin periosteal reaction, which is very specifically associated with malignant tumors, in this case Ewing sarcoma. So this is the onion skin appearance, and what we are going to be thinking about is Ewing's sarcoma. Alright, so this is Ewing sarcoma, diaphyseal tumor in a child, mimics inflammation, and there is onion skinning appearance on radiology. Histopath wise, this is very, very important. So histopath features two things. It is one, a small round blue cell tumor. You can see how it is so hypercellular. So this is a small round blue cell hypercellular tumor, and you'd also see these rosettes. Is this a true rosette? No. Anything where the center is non-empty is not a true rosette, right? So you can see these neuropils here. So this is what we call as the Homer right pseudorosettes. We also see them in medulloblastoma, if you remember, okay? So Homer right pseudorosettes with central neuropil is something that you would see here. Now, radiotherapy will also discuss the principle of what is radiosensitive. Therein I'll tell you, anything that is very cellular, anything that is rapidly dividing is something that is radio sensitive. So that is why, because there are so many small round blue cells, because it is so hypercellular, this is the most radio sensitive, the most chemosensitive bone tumor. Repeat question, okay? So this is the most radiosensitive or chemosensitive bone tumor that we have, and you want to remember here that the treatment of choice, that is why, is going to be CT-RT. You're going to be doing a chemoradiotherapy and it literally melts. It is so radiosensitive, it literally melts on giving radiotherapy. Okay, so this is what you want to know about Ewing sarcoma, child inflammation onion skinning, pseudorosettes, and you have small round blue cell tumor. Okay. Now, the third diaphyseal tumor, here you just want to remember that this is very specific to tibia. Only when the tibial bone is shown to you, you want to think of this, and this is something which is a very eccentric sort of a lesion. It is much more anterior, alright. So, this is eccentrically based on the tibia anterolateral lesion. You want to think of adamantinoma. So, this is adamantinoma. Remember, tibia, diaphyseal bone lesion, and eccentric. Okay, so these are the three buzzwords that you want to remember for adamantinoma. So this takes care of epiphyseal tumors, ECG, three diaphyseal tumors, osteoidostoma, Ewing sarcoma, adamantinoma. After that, we have metaphyseal lesion, and this is the most important, the most common primary malignant bone tumor. This is osteosarcoma. So osteosarcoma, remember, has a bimodal age distribution wherein we can have primary osteosarcoma or secondary osteosarcoma. Primary is something that is seen in children less than 20, whereas secondary bimodal peak would be seen in elderly patients. The risk factor for secondary osteosarcoma are going to be radiotherapy exposure, or somebody who is having Paget's disease can also secondarily develop osteosarcoma, but this is all gonna happen in elderly patients, not in young people. Okay, so this is about the demographics. Now coming on to radiology, because it is osteosarcoma, it's a bone forming tumor, you're not gonna see lysis, you're now gonna see a lot of sclerosis. If you look at the matrix here, what I mean by matrix is overall density of the tumor. This is very, very dense. It is so white that it looks like ivory. So this is what is called as the ivory pattern, the ivory matrix, which tells you that this is indeed a bone forming tumor. It is an osteosarcoma. So that's the osteo part, which we can guess by the matrix. What about the malignant part? So now you look at the periosteal reaction. We can first of all see how it is going out from the cortex. There is soft tissue component, and we look at the periosteal reaction, which is lifted like this. So this is what is called as the Codman's triangle. If you remember, I told you Codman's tumor is chondroblastoma. This is Codman's triangle, which is definitely a sign of a malignant bone tumor. In addition, you can see how these bony spicules are all perpendicular to the bone. This is what we call as the sunburst periosteal reaction. So you are having the bone growing along the blood vessels perpendicular to the bone. So we have two aggressive periosteal reactions. We have the Codman's triangle and we have the sunburst periosteal reaction. This is also a repeat question wherein they showed you a gross specimen of osteosarcoma, but again you can see how it is metaphyseal and is so aggressive, it is invading into the soft tissue, right? Based on this, you can know that this is indeed osteosarcoma. Alright, so metaphyseal tumor, very white, very bone forming, and you have aggressive periosteal reaction. As far as the treatment is concerned, first thing which is also a repeat question is what you want to remember, that this is the most radio resistant bone tumor. We just talked about Ewing sarcoma, that's the most radio sensitive bone tumor. This right here is the most radio resistant bone tumor. Pretty ironical considering it occurs because of radiation as a risk factor, right? So it itself is radio resistant, but radiation is a risk factor for osteosarcoma to occur. Okay, so then the treatment is basically surgery. So surgery is the mainstay of treatment here for osteosarcoma. If it is unresectable, then pre-op chemotherapy can be given. Okay, so pre-op chemotherapy can be given if unresectable, otherwise surgery is the mainstay. Okay, so this is what we want to know about osteosarcoma. Now, while we are on metaphyses, I want you to know of two bony cysts. So these are two bony cysts in the metaphyses. One is a simple bone cyst, also called as a unicameral bone cyst. Okay, so simple or unicameral meaning there's just one cavity here. Simple or unicameral, we call it SBC or UBC. The other differential here is an ABC, which is aneurysmal bone cyst. So ABC, aneurysmal bone cyst. Okay, so here what we have to see is in a simple bone cyst, there's just serous fluid which is there. So it is going to be this metaphyseal well-defined lesion. You can see this is the epiphysis and this is within the metaphysis. So it's a well-defined metaphyseal geographic lytic lesion, and what you see here as a hallmark is there's one floating fragment. Can you see that there's a pathological fracture here and that fragment of bone is floating within the cyst? Okay, so this has been given the name of fallen leaf sign or trapdoor sign. Okay, so this is the fallen leaf sign or the trapdoor sign. Typically an SBC is going to be seen in people less than 20 years of age, while in an aneurysmal bone cyst, again see this is the epi, so this is the metaphysis. So here you can see there is a well-defined geographic lytic lesion and you have a soap bubble appearance. Like we saw with GCT, here also there is a soap bubble appearance. Here the age is not really specific, so you can see it in less than 20 years also, more than 20 years also. Okay, so like in this case you can see it's a child because the growth plate is not fused. So how you want to actually distinguish them is look at the matrix. Here it's a very simple matrix, it's not having any septae, but there's a fallen bony fragment, while here there are multiple trabeculations and it has a soap bubble appearance. Okay, so this is about SBC and ABC. Now we're talking about a bone tumor which is growing away from the bone. So far we had the epicenter inside the bone and then if it was aggressive it would spread out. But this here is a lesion which is primarily growing as this mushroom here. This entity is osteochondroma, also called as an exostosis. A lot of people believe it is not even a true bone tumor. Okay, so they consider it to be a response to some sort of a congenital vascular accident. Okay, so this is an osteochondroma or an exostosis which is growing outside. Exo meaning outside, growing outside the bone. So this is osteochondroma. As the name says, there is osteo component and there is cartilaginous component. So what do you think we can see on the X-ray? I can only see the bony part here, right? So this is the bony part of the osteochondroma that we can see, but not the cartilaginous part. So then what do I have to do to see the cartilaginous part? Investigation of choice is MRI. So when I look at this image, can you see how there's an MRI? This is the bone marrow which continues here with the exostosis, and you can also see one cap. So this is the cartilage cap and this is what makes it osteochondroma. So now a question will arise in your mind, if I'd already made the diagnosis, why see the cartilage cap in the first place? So that is what is very important, that osteochondroma has a risk of developing into chondrosarcoma. It doesn't develop osteosarcoma, but it develops chondrosarcoma, and to diagnose it, I have to see the cartilage cap thickness. I can monitor these patients on MRI, see their cartilage cap thickness, and if the cap thickness is more than 1.5 centimeter, that is a sign that the patient is developing chondrosarcoma and must be taken up for resection. Okay, so all of these patients of osteochondroma are kept on follow-up. They get routine MRIs done, and when this cap here measures more than 1.5 centimeter, it needs to be resected. Okay, so that is osteochondroma. Now it can also be multiple. You can also have multiple osteochondromas in certain patients, which is a hereditary syndrome. So that is given a simple name of HME, that is hereditary multiple exostosis. Okay, so this is called as hereditary multiple exostosis and also given the name of diaphyseal eclasis. So called as diaphyseal eclasis. The importance is there is higher risk of malignancy as compared to those having a single lesion. Okay, so there's a higher risk of malignancy which could be somewhere around 3 to 20%. So a wide range, somewhere around 3 to 20% higher risk of malignancy. Okay, so that is what you want to remember as far as osteochondroma is concerned. Now we talk about this image here, very frequently tested. So anytime they give you the hand x-ray, you are seeing these multifocal lytic lesions. Can you see this? All of the hand tubular bones are showing you these geographical lytic lesions, and you can see that there is this stippled sort of white calcification here. This tells you that it is enchondroma. Remember hand and enchondroma in the hand x-ray. Okay, this enchondroma, cartilaginous lesions, these are benign tumors in the short tubular bones of the hand. Here you want to remember two syndromes. So enchondromas are frequently multiple if there are only enchondromas, meaning you are seeing multiple enchondromas, that is called as Olier's syndrome. So O for only enchondromas, Olier's syndrome. But when you see that in addition to the enchondromas, there are also soft tissue lesions. There are hemangiomas. Hemangiomas are vascular lesions. So when you see there are phleboliths, there are bluish lesions, they give you a clinical image, the syndrome becomes Maffucci syndrome. So that is Maffucci syndrome that you want to remember here when there are hemangiomas in addition to the bone tumors. Okay, so this is enchondroma. Next, we want to talk about a lesion of the metaphysis which frequently affects the femoral metaphysis. Here you can see that there's a tumor which is having a very ground glass sort of matrix. What I mean by ground glass is neither lytic, it's neither sclerotic, it's somewhere in between. Just like we saw ground glass in the HRCT chest with COVID-19, it was this hazy appearance. Same hazy appearance if you see in the bone. Better seen in the CT. You can see how there's a CT coronal of the face. Look at how all of the bones are expanded and having this grayish sort of a color. So this lesion that I'm talking about is fibrous dysplasia. So most commonly a solitary fibrous dysplasia is seen in the femoral neck. Okay, so when it is seen in the femoral neck, a lot of times there can be associated fracture, like in this case, and you see how the femur is bent. This deformed bone is called as the Shepherd crook deformity. So this is the Shepherd crook deformity associated with the femoral neck fibrous dysplasia. A lot of times it could be polyostotic, meaning it can involve multiple bones. This is polyostotic fibrous dysplasia, which can frequently involve the craniofacial bone. So this is craniofacial polyostotic fibrous dysplasia. Clinically, if you look at the patient, they'll show you this leonine sort of phases, very expanded bone. Something that we also learn in leprosy. Yeah, so very leonine phases are going to be seen in craniofacial FD, which is a type of polyostotic fibrous dysplasia. Here you want to remember two syndromes. One is a McCune-Albright syndrome. So there's a McCune-Albright syndrome wherein polyostotic FD is associated with precocious puberty. So they'll give you history of precocious puberty here, or it could be Maza-Brout syndrome. Maza-Brout syndrome is associated with multifocal myxomas. Okay, so two M syndromes, Maza-Brout, McCune, this is going to be precocious puberty, whereas in Maza-Brout syndrome, you're going to have multifocal myxomas. Okay, so this is about polyostotic FD. So what we remember from fibrous dysplasia, you remember Shepherd crook, you remember polyostotic, you remember ground glass matrix because it's a fibrous matrix. There is fibrous tissue there. When you look at the histopath, because there's a lot of woven bone here giving rise to the fibrous matrix, this arrangement is called as a Chinese letter arrangement. So this is your Chinese letter appearance on histopath of this fibrous dysplasia. With this, you can also recall Chinese letter also seen in Corynebacterium diphtheria, right? So in diphtheria also you have the bacteria being arranged in a Chinese letter arrangement, okay? So this is about fibrous dysplasia. Next, we want to just do a few spotters. Alright, so these are not very commonly asked, but I just want you to be oriented to the images here. So in the first one, you are having, let's say, an elderly person. I give you the history. That's an elderly person presenting with a very large mass in the proximal thigh. When you look at the X-ray, you have this large soft tissue with aggressive ring and arc sort of calcification. Can you see this calcification? This is described as ring and arc calcification. This large soft tissue, aggressive nature of the mass suggests that it's a malignancy. So what is this? This is a chondrosarcoma. Okay, so this ring and arc suggests chondroid matrix, cartilaginous matrix, and this large soft tissue growing away from the bone suggests that it's a malignant tumor. This age also fits with chondrosarcoma, and also the pelvis, most common site of chondrosarcoma developing is indeed the pelvic bones. Alright, so this is chondrosarcoma. Very typical tumor in the skull. What you are seeing is a very bony matrix. Can you see how it's just like the bone cortex here? So this is a cortical based osteoma, benign bone forming tumor. So this is osteoma. One question here gets asked is what is the syndrome? So this is associated with Gardner syndrome, right? So Gardner syndrome, wherein you're going to have FAP, which is your polyposis, adenomatous polyposis in a familial manner. In addition, you can also have soft tissue lesions like sebaceous cysts, you can have supernumerary teeth, you can have osteomas, you can have fibromas, right? So that is in context of Gardner's that, this image can be provided, and something very specific to the calcaneum. When you see that within the calcaneum there is this lytic lesion and there is a central dot of calcification, this is an intracalcaneal or an intraosseous lipoma. So an intraosseous fatty tumor, that is a lipoma. Alright, so this is very typical appearance within the calcaneum wherein you have a well-defined lesion with central calcification. Okay, so this is what you want to remember as far as these tumors go. Now, talking about the spine, just one thumb rule that you want to understand, that in the spine, we have the anterior vertebral body and then you have the posterior elements. The general rule is that within the anterior body, we are going to have malignant tumors or basically metastasis. The only exception is a hemangioma, which is the most common benign tumor of the spine in body of the vertebra. As far as the posterior elements are concerned, the norm is that there are going to be benign tumors like say an osteoblastoma or an osteoid osteoma. The only exception is metastasis. Metastasis can definitely come and live in the posterior elements. Alright, so this is the general rule. What you want to remember here is this appearance of hemangioma. So on a sagittal cut of the CT, you see how there are these different bony trabeculae which have become prominent. This is called as the jail bar appearance or the quadroid cloth appearance. So this is the jail bar appearance of hemangioma on a sagittal plane. If I take an axial cut, you'll see the different trabeculations and this looks like the polka dot pattern. So jail bar or quadroid or polka dot sign, these are all signs of hemangioma, a benign tumor, and the most common site of osseous hemangioma is indeed the spine. Okay, so this is something that we encounter very frequently in the routine CT scans. This is a hemangioma. Alright, so this takes care of the bone tumor section of our topic here. Next, we want to talk about arthritis. So now in arthritis, what we are going to do is we're going to adopt a very systemic integrated approach. So I'm going to tell you how to approach these arthritis. I don't just want to show you the X-ray signs because here the questions are going to be asked in a clinical integrated sort of a manner. Okay. So what we are going to do is we'll approach this into two types. First, when you have an acute inflammation, when you have an acute arthritis which is typically monoarticular, or when you have a chronic sort of a multifocal joint disorder. Okay, so here there are two differentials. One, it's going to be gout. Second is pseudo gout. Alright, so now let's have a look at the images. In the first one, they'll give you the history that there's an elderly person, typically an elderly male, who's having this acute pain and redness and swelling in the first metatarsophalangeal joint. This is the most common joint to be involved. First metatarsophalangeal. A foot x-ray has been given and you can see how there are these big lytic lesions looking as if there is a rat bite which has happened. Okay, so this is what we call as rat bite erosions. And you can see that there are these overhanging margins. So rat bite erosions, overhanging margins, and this we call as the Martel G sign. So this is the Martel G sign. It is frequently associated in alcoholics. You'll get this history that there's alcoholic binge episode because of which there's hyperuricemia and you have an acute attack of gout. Okay. So, radiology wise, large rat bite erosions, Martel G sign, and one recent advance here. So, this is a special type of CT, that is a dual energy CT, in which the concept is material decomposition. So, material decomposition meaning I can actually guess what is the deposition agent on the basis of the CT principle of dual energy CT. So, in this way I can actually distinguish what is uric acid, what is calcium, and we can give this distinct color to uric acid. So, this in the nutshell can show you where all you have deposition, not just the joint where you have the erosion, but also you can see how there is subcutaneous deposition in the form of tophi, right? So, in gout, we know there could be subcutaneous depositions which are called as tophi that also can be picked up. So, the recent advances DCT for gout that you want to remember. So, now in gout or in pseudo gout for that matter, which are crystal arthropathies, remember the investigation of choice is aspiration. You got to do synovial aspiration and you want to look for these crystals. So, in gout, what is the crystal which is deposited? It is MSU, that is monosodium urate crystals which are deposited. What I mean by pseudo gout is when you have deposition of CPPD. So, this is calcium pyrophosphate. So, here you have calcium pyrophosphate crystals which are deposited and hence the name CPPD, which is calcium pyrophosphate deposition. Okay, so they differ in the crystals. Secondly, they differ in the joints which are affected. So, here we saw it's the first MTP which is most common, whereas for pseudo gout it's going to be the knee joint which is most common. What you see in CPBD is chondrocalcinosis. What is chondrocalcinosis? Chondro meaning cartilage, calcinosis meaning calcification. So, there's calcification of the different cartilages. So, in the knee, you would have the menisci. Can you see here that the menisci are calcified? So, that is the finding that you will see in pseudo gout. So, you would also have various associations which are mentioned with pseudo gout. So, you can have associated hypothyroidism or you can have associated hemochromatosis which is mentioned. Okay, so this is in a nutshell the topic of pseudo gout. So, gout versus pseudo gout, both will have acute presentation. If acute pain in MTP, think gout, rat bite erosions. If acute pain in knee, elderly patient, hypothyroid, hemochromatosis, menisci calcification, think pseudo gout. As we discussed, investigation of choice is aspiration. In that, we'll run this fluid under a microscope. A lot of times, we'll use a polarizing microscopy, and that is going to show you the crystal morphology and the crystal birefringence. So, just to integrate, when you see needle-shaped crystals, just negatively birefringent. Alright, so when the needle-shaped crystals are negatively birefringent, an image like this might be given. You think these are monosodium urate crystals and the diagnosis is going to be gout. But when these crystals are rhomboid shape, you can see the rhomboid shape here and they are positive. It's a weakly positive, but it's a positive birefringence that you are seeing. Here the crystals are CPPD. Calcium pyrophosphate deposition here, and the diagnosis is going to be pseudo gout. So, you can remember NENE, needle and negative for gout, rhomboid and positive for CPPD. Okay, so this takes care of crystal arthropathies. Next, we want to discuss the approach to chronic polyarthropathy. So here, the main approach is going to be whether it is inflammatory or non-inflammatory. That is going to be our next point that we want to use to distinguish and narrow down our differentials. So in chronic arthropathy, how to know whether it's inflammatory or non-inflammatory? One, the presence of the swelling. Second, the morning stiffness. When there is morning stiffness more than 45 minutes, it suggests an inflammatory nature. If there is ESR CRP which is positive or raised, again suggests inflammatory. And joint fluid analysis, when it shows you that the WBC count is raised, there's a turbid nature to it, we will again say that it is inflammatory. So looking at the nature, we can guess. Apart from that, remember, overall in inflammatory arthritis, here the pain and the swelling are going to be increasing with rest and they reduce with activity. Whereas in non-inflammatory, you have this pain which is increasing with activity and it reduces with rest. Okay, so that is something which is the hallmark of inflammatory versus non-inflammatory arthritis. So based on the history, clinically, you will be able to reach till here. Now further, they'll show you the image or they'll describe the findings and they'll ask you the diagnosis. So that's precisely what I've done in a very concise manner for you. Okay. So now if we have inflammatory arthritis and the clues given are that there is multifocal involvement of the small joints. There's a symmetrical involvement of the small joints wherein both the hands are involved and all of the joints are being involved in a symmetrical manner. So that's the first point. There is symmetrical joint space reduction, symmetrical joint involvement. Then you have a predominant osteopenia. You can see how the bone density is reduced and the hallmark here is erosions. There are marginal erosions. What am I talking about? Yes, we are talking about rheumatoid arthritis. So rheumatoid arthritis, remember, associated with HLA, DR4. You can remember 4. A rheum has 4 walls. So rheumatoid is DR4. The most common joint to be involved here is the metacarpophalangeal joint. So the metacarpophalangeal joint, this joint right here, is the most common to be having these erosions. So you can see how there are so many marginal erosions which are associated, and because it's inflammatory, there is osteopenia and you have a symmetrical joint space reduction. So this is what you want to remember. And something very important, which joint is spared? There is sparing of DIP joint. So the distal interphalangeal joints are typically not involved in RA. So remember the most common MCP, sparing of DIP. Next inflammatory arthritis that we want to discuss here. So you get this X-ray and you see how DIP and PIP are most common. So distal interphalangeal is actually the most common to be involved. What you have is these marginal erosions with viscerae. That is nothing but the periosteal thickening. Look at this. We're having this severe destruction wherein it looks like there is a pencil within cup appearance. There is destruction of bone, meaning there is osteolysis. Digits are telescoping into one another, and sometimes you can have a very rare variant which is called as arthritis mutilans, wherein you have a lot of destruction, and this gives rise to an opera glass deformity. So this gives rise to opera glass deformity. What we are talking about is psoriatic arthritis, and the biggest clue that you will get here is that skin and nail changes are present. So they will give you history that there are erythematous lesions with silver scales on the extensor. You have associated irregular pitting, you have oil drop changes. So these would be associated, and associated with that, telescoping is the buzzword that you want to look for. The most common type is the oligoarthritis type, wherein you have the DIP getting involved most commonly. Okay, so this is psoriatic arthritis. The last inflammatory arthritis simply will have a buzzword wherein there are deformities. Just like we have deformities in rheumatoid such as swan neck, bottom ear, you do have deformities, but then there are no erosions. What is this? So this is a typical feature of SLE arthritis, which is also called as Charcot's arthropathy. So this is SLE or Charcot's arthropathy, which is a non-erosive arthritis but does have deformities. Okay, so these are the three inflammatory arthritis that we want to remember. RA is the prototype of inflammatory arthritis, wherein you have erosions, you have joint space which is symmetrical. You also want to remember that there is going to be osteopenia. If you see telescoping, skin changes, nail changes, think psoriatic arthritis. And the last one being SLE or the Charcot's arthropathy, which does not have erosions but does have deformity. Okay, so this takes care of inflammatory side of things. Now, when you have clinical features like a non-inflammatory arthritis, here the prototype is going to be osteoarthritis, right? So you would get an elderly patient who's having large joint involvement. So hip and knee would be most common. If the hand is involved, remember DIP can be involved, PIP can be involved, and the most common is the first carpometacarpal. So the base of thumb is what is most common in the hand. Overall, it's the larger joints which are far more common. So the moment you see a hip and a knee X, you're going to start thinking on the lines of osteoarthritis. Look at this X-ray. You can see how the reduction is asymmetrical. The medial joint space is affected more than the lateral joint space, and in contrast to rheumatoid arthritis or inflammatory arthritis, where you had symmetrical, here you have asymmetrical joint space reduction. There you had osteopenia, meaning the bone density was reducing. Here you will have sclerosis. Can you see this white rim? So you're going to have sclerosis here. There you had erosions, bone getting eaten up. Here I'm going to have new bone formation. Can you see this? These are osteophytes, new bone formation. So three opposite things. This is asymmetrical, that was symmetrical joint space narrowing. There you had erosions, here you're going to have osteophytes. There you had osteopenia, here you're going to have sclerosis. Okay, so the markers of non-inflammatory or degenerative arthritis, osteophytes, sclerosis, and asymmetrical joint space narrowing. So now in osteoarthritis, also remember that we have subcutaneous nodules. There are two kinds of nodules, one at the DIP and second at the PIP. At the DIP, that is the distal interphalangeal joint, the nodes that we have are Heberden nodules, and the nodules that we have at the PIP are called as Bouchard nodules. How you want to remember this is DHBP. So in the first year, we know DH, dissection hall, we know blood pressure, how to measure blood pressure, right? So that's how you can remember DH. So DIP, Heberden nodules, Bouchard at PIP nodules. So that's about osteoarthritis, the prototype non-inflammatory arthritis. Next, what we want to discuss is another form of non-inflammatory arthritis, wherein the hallmark is going to be a lot of destruction. In fact, the typical buzzword or the phrase that's mentioned here is that on looking at the X-ray, you would be worried for the patient. It looks really bad, but the patient says, I don't have any pain, I don't have any symptoms, right? So it looks bad but doesn't feel bad. And why that is so is because it's a neuropathic joint. It's a joint or it's an arthritis that happens in patients who have neuropathy, meaning they cannot feel the pain, and that is why the arthritis progresses to a very severe degree on the X-ray. The destruction is too much, but the patient presents late because of absence of pain, right? So the hallmark of neuropathic joint, or this is also called as Charcot joints, right? The other name of this arthritis is going to be Charcot joint. In this, most commonly the history would be that of diabetes. The most common type is that for diabetes mellitus, wherein you have the foot mid-tarsal joints which are involved. So in diabetes mellitus, the most common joints to be involved are your tarsal, intertarsal joints. Whereas other causes could be leprosy, syringomyelia, also where the sensory loss is present. So on the X-ray, the hallmark here are the 5 Ds. So you're going to have a lot of disorganization. As you can see, there's a lot of destruction happening. There is high density of the bones, and you have a lot of debris as well as distension. Okay, so those are the 5 Ds: disorganization, density, destruction, debris, and distension. No need to remember this per se, but just get an overall idea that when you have destruction of the foot bones or the intertarsal joint, always consider diabetes mellitus, always consider a neuropathic joint. Next, when you have a child who's coming to you with swelling of the knee joint, in fact, you would get the history that this child has recurrent hematomas on the skin, has recurrent hemarthrosis, which is joint swelling, you will directly suspect hemophilic arthropathy, right? So this is a very, very typical presentation in hemophilia. You have bleeding in the joint. So this is hemophilic arthropathy. The finding hallmark you want to remember here is that this intercondylar notch becomes widened. In addition, because of recurrent bleeding, you can also have a squared patella. They would also give you history of pseudotumor, which are these swellings in the muscles because of the recurrent hematomas in the muscles also occurring, which appear like a tumoral swelling, but it's actually a hematoma. Okay, so this is hemophilic arthropathy. The hallmark here is going to be intercondylar notch widening. So this is our approach to any arthritis that they want to ask in an integrated fashion. Remember, inflammatory, wherein you're going to have morning stiffness, you're going to have pain that improves on activity. Prototype, bilateral wrist joints, bilateral metacarpophalangeal joints getting involved, rheumatoid arthritis. Then if they ask you that there is DIP involvement, associated skin lesions, nail lesions, think psoriatic arthritis. One specific type is SLE Jacob's arthropathy, wherein you have deformities but there are no erosions. Going on to non-inflammatory, elderly patient with large joint involvement or the presence of thumb, base of thumb, that is first carpo-metacarpal joint involvement, think of osteoarthritis. In addition, if you have the foot bones getting involved, intertarsal joints, looks bad, doesn't feel bad, think neuropathic arthropathy. And hemophilic arthropathy is when you have a child with recurrent hematomas. Okay, so this is our approach to arthritis. Now talking about spondyloarthropathy. So here you are going to have the presence of predominantly axial, that is spine involvement, and also peripheral joints getting involved. And the prototype of this disease is ankylosing spondylitis. Very, very important. In fact, this is the most frequently asked question from the whole topic of MSK radiology. Herein, you would have the history of a young male, a young adolescent male in his 20s or 30s, presenting to you with inflammatory kind of backache. This inflammatory backache means, just like the rheumatoid arthritis clinical picture we saw, here you're going to have this pain which decreases or improves with activity, whereas it increases with rest. Okay. Eventually, this pain is now going to be replaced by this limited mobility. So now there's going to be limited mobility of the spine. You can also have limited chest expansion, which is associated. There could be other systemic manifestation like anterior uveitis. There could be associated cardiovascular issues in the form of conduction block. There could be valvular lesions which are associated. And something that has been tested in the past is enthesitis. So what is the meaning of enthesitis? Wherever you have tendons and ligaments attaching on the bone. For example, let's say this is the calcaneum. We have the Achilles tendon attaching here. At the attachment site, you're going to have inflammation. So the pain at the attachment site of tendons and ligaments is called enthesitis, and that is what is associated with angstpond. One important clinical sign that can be tested here is for limited spinal flexion that happens when the spine is completely fused. This test is called as a modified Schober's test. So modified Schober's test is basically going to test the fixation in the flexion of this person's spine because of the fusion. Okay, so I hope now the term ankylosing spondylitis is clear. There's inflammation which then progresses to fusion, that is ankylosis. But is it the spine that is involved the first? No. The first thing to be involved here are the sacroiliac joints. So you want to remember that the earliest manifestation here is sacroiliitis. So the investigation of choice for that, or the other way of asking, what is the most sensitive investigation that can pick up the earliest finding, that is sacroiliitis? The answer is going to be MRI. So MRI is the investigation that is most sensitive and best to detect the inflammation of the SI joints. The sequence that we do on MRI is the STIR sequence. If you remember from our MRI discussion, anytime I want to pick up bone marrow edema, I will suppress the fat in the bone marrow, only then the edema gets picked up. Okay, so STIR, which is short tau inversion recovery, is a fat suppressed sequence wherein all of the bones appear black. The bone marrow has been suppressed so that the inflammation or the bone marrow edema stands out. So this is a coronal MRI of the SI joint. I hope you can make it out. This is the sacrum and these are the iliac blades. So this is the joint here. You can see that on both the sides. Yeah. So this is the sacral side and this is the ilium bone here. On both the sides you can have this white edema here. So this denotes the bone marrow edema, which is sacroiliitis. So for ankylosing spondylitis, bilateral asymmetrical sacroiliitis is the rule. If you see unilateral sacroiliitis, do rule out tuberculosis. Okay, so this is just one differential, that if there is unilateral sacroiliitis, one differential to consider is tuberculosis. Okay, so this is how it starts with sacroiliitis. Eventually what's going to happen is these SI joints are completely going to fuse, hence the term ankylosing. Right, so we're going to have bony ankylosis and both the SI joints are then going to fuse. So this is an X-ray of the pelvis which is showing the fusion of the two SI joints. Right, so this is about the SI joint. Now simultaneously we are having the spine also, which is going to show you changes. So what happens with the spine? So the earliest thing that's going to happen here is the inflammation of the end plates. So you know there are these Sharpie fibers which attach the IV disc to the bony edges. So because of this attachment site, also this is a type of enthesitis only, at the attachment site of these fibers you're going to start to have inflammatory changes. Can you see in the zoomed in image how there are these sclerotic irregular margins at the edges? This is called as the Romanus lesion. So this is called as the Romanus lesion or also called as shiny corner sign. So this is called as Romanus lesion or shiny corner sign, which is basically going to be the inflammation and irregularity at the bony end plates. This is how it all starts. After this inflammation is triggered, now there are going to be these reactive bony changes. Now there's going to be new bone formation, these vertical bony bars which are going to connect the spine. These bony bars are called as syndesmophytes. Alright, so after the inflammation, after the shiny corner, what we have is the syndesmophyte formation. These syndesmophytes are going to connect the entire spine. They're going to cause the fusion of the entire spinal column. In addition, after the fusion of the entire spinal column, we also have calcification. The interspinous ligament can get calcified. So whenever you see a combination of this, look at the lateral X-ray of the spine and the AP X-ray of the spine. In the lateral X-ray, you can see how the complete spine is fused here. There's a complete smooth fusion of the spine at all joints. Anterior vertebral, posterior vertebral as well as posterior elements are fused. In the AP view, you can see how there is this fusion. There are these syndesmophytes and in addition, there is ossification of the interspinous ligament. Okay, so this gives rise to various named signs which are asked in the exam. So they give you these images and they ask you image-based questions, or they can ask you a theoretical question on the basis of the names here. So what you have is, this is called as the bamboo spine. The whole spine is fused like a bamboo. That's why there was limited flexion that we studied in the Schober's test, right? So this is called as bamboo spine. And on the AP view, you have these three lines here going together. That is referred to as tram track sign, also called as dagger sign. So this is called as tram track or dagger sign. This calcification of interspinous ligament looks like a dagger. These three lines together look like tram track. Alright, so all of these are the named signs: Romanus lesion, shiny corner sign, tram track, dagger and bamboo spine here. Okay, so this is what you want to remember about Angst-Pond. Now one differential, this is a repeat Ames question which was asked around 3 years back, is the differential of Angst-Pond in elderly patient. So in elderly, you have this flowing sort of ossification. Look at this X-ray here. There is this flowing sort of ossification only along the ALL, that is anterior longitudinal ligament. So I can see that there's this fusion which is happening only anteriorly. There's no fusion happening anywhere else. On the other hand, in Angst-Pond, you have the smooth fusion throughout all of the joint spaces, right? So this differential here is called as DISH. DISH stands for diffuse idiopathic skeletal hyperostosis. So this is diffuse idiopathic skeletal hyperostosis that is seen in elderly population. So age group is going to be a very, very important clincher for you. Here you have patients who are invariably more than 50 years of age, and the ossification is only along the ALL, only along the anterior longitudinal ligament, and this is called as the candle wax appearance. It looks as if the wax is dripping down the anterior longitudinal ligament. On the other hand, in Angst-Pond, what we are going to have is, we're going to have a young male patient who's going to have a complete fusion of the spine, right? So this is not just anterior, but a complete fusion of the spine is going to be seen here. So this is how you distinguish DISH versus Angst-Pond on the basis of the X-ray here, okay? Now one more differential, just like how we saw DISH, diffuse idiopathic skeletal hyperostosis along the ALL, there can be ossification along the posterior longitudinal ligament as well. You can see how along the PLL, that is the posterior aspect of vertebral bodies, you have this ossification. So this here is DISH, that is ossification along the ALL. This is also called as Forestrier's disease. On the other hand, here when you have ossification along the PLL, this disease is called as OPLL, ossification of posterior longitudinal ligament, and the other name of this disease is Japan's disease, okay? So this is OPLL. Now when I ask you what's the difference, which is going to have more likelihood of spinal canal stenosis, very logical, because PLL is going to impinge on the spinal canal. This has higher chances of being symptomatic. This has higher chances of spinal canal stenosis and hence cord compression. Whereas here in DISH, you have ossification along the ALL, which doesn't really cause this. So you don't have any cord compression or spinal canal stenosis. The only presentation is going to be this diffuse sort of a backache. Okay, so this is about DISH versus OPLL. All right. Now, one specific case scenario wherein I'll just tell you one clue and you'll never get this wrong. So let's look at this question. A 39-year-old female with multiple small joint deformities present to you with neck pain. The X-ray is shown in flexion and extension. What is the diagnosis? So the clincher here is anytime they show you a dynamic X-ray. A dynamic X-ray meaning there is flexion and extension views. Always remember we are testing for the instability of the spine. We are testing for dislocation or spondylolisthesis, which is slipping of one vertebra on the other. In this case, in cervical spine, the diagnosis is atlantoaxial dislocation. So whenever in the exam you see this paired flexion extension X-ray, always consider atlantoaxial dislocation. So what we see here is the distance between the atlantoaxial joint. So basically this is the distance that you are evaluating. Here this is the anterior process of the atlas and this is the dent. So we measure this distance in flexion and then we measure this in extension. Any distance which is more than 3 millimeters is considered to be AAD. Now, out of the given options, septic arthritis, RA, gout and TB, remember rheumatoid arthritis doesn't really have lower or lumbar spine involvement. It has cervical spine involvement and the most serious complication is RA. So, rheumatoid arthritis tends to affect the atlantoaxial joint most commonly. Okay, so that is what you want to remember here. Anytime they show you a dynamic flexion extension view, always consider AAD, that is atlantoaxial dislocation. Okay. Now we begin the discussion of metabolic bone diseases. Here we want to talk about a lot of systemic disorders which are going to have a lot of overlap with medicine and peds. So again, we're going to be doing this in an integrated manner. I tell you the metabolic profile in each of these. Those are the kind of questions that you get, wherein you need to be aware of the calcium, phosphate, PTH parameters here. You want to be aware of the radiological parameters here. So now beginning with the first important disease here, that is rickets. Rickets, as you know, is a vitamin D deficiency in the growing skeleton. So in a child, if you have vitamin D deficiency because of any reason, that is rickets. So now what does vitamin D deficiency lead to as far as the biochemical profile is concerned? What happens to calcium, phosphate, PTH and ALP? These are the four markers that are frequently going to be given to you in the question or going to be asked to you as questions. So if vitamin D is deficient, remember the calcium phosphate absorption both are affected. So we are going to have low calcium, low phosphate. Anytime in the body the calcium level drops, what happens to PTH? PTH increases, and if PTH is increasing, meaning bony resorption is increasing, the ALP, which is a marker of bone formation, also increases. So we have this sort of a biochemical profile wherein both are in the same direction. Remember this thumb rule as far as biochemical profile is concerned. Whenever it's a vitamin D pathology, calcium phosphate go in the same direction. But whenever it's a PTH problem, parathyroid primary problem, calcium phosphate run in opposite direction. Remember this thumb rule, we keep applying it as we go along. Okay. So vitamin D deficiency, calcium phosphate both are low. Now radiologically what's going to happen? Because vitamin D is not there, calcium is not there in a growing skeletal, where at the growth plate we are having these cells, the cartilage cells, which is maturing and getting calcium and then forming the metaphyses. So this is all happening at the growth plate, wherein you are having cells which are maturing in size, increasing in size, and then we have one zone of provisional calcification where they get the calcium and then they keep integrating into the metaphyses. So can I say that in rickets, the zone of provisional calcification is the one which is not working? Yeah. So the earliest sign of rickets is the fact that the zone of provisional calcification in the growth plate is deficient. Correct? And how it presents radiologically or clinically is the widening of the growth plate. If you see the wrist of a child with rickets, you're going to have the growth plate getting widened. So widening of growth plate is the earliest sign of rickets. Important question. Further on, what's going to happen? Because you have all of these cells here waiting for the calcium to come, they're all going to apply pressure on the metaphyses. Resultantly, we're going to have this irregular metaphysis which is widened, that is played, and it can also look like a cup. So three phrases are associated here. You have fraying, that is irregularity. You have cupping or the splaying, that is widening of the metaphyses. So three changes happen with the metaphyses: fraying, cupping and splaying. Alright, so this is what happens in rickets in the metaphyses. Let's say I start to treat. I've made the diagnosis, I've started the patient on vitamin D. That is the treatment here. Give the patient vitamin D because that's the deficiency. What is going to be the change? So on healing rickets, remember when the rickets is healing, the X-ray is going to show you this white line. There's going to be sclerosis at the metaphyses because suddenly you have so much calcium which is coming in. All of your cells which were waiting for the calcium are now going to be mineralized and you'll have this sclerotic line. And this line is called as white line of healing rickets. So white line in the metaphyses is what you will see. Now, remember this, in scurvy also we're going to have this white metaphysal line which we call as Frankel's line. So the term Frankel's white line is reserved for scurvy. It is not something that you would use for rickets. So Healing rickets, white metaphyseal line is what is going to be associated. How to distinguish it from scurvy? So healing rickets versus scurvy. Remember, healing rickets, you're still going to have this irregularity. But in scurvy, it's going to be a smooth white metaphyseal line. Okay, so this is about rickets. So on the same line, we also want to talk about scurvy, which is nothing but vitamin C deficiency. So in rickets, vitamin D led to deficiency of mineralization, that is, calcium was not there. In scurvy, what happens is vitamin C, as you know, is very, very important for collagen synthesis, that is hydroxylation of lysine and proline. This step here in collagen synthesis is dependent on vitamin C. So when this does not happen, we do not have collagen which is forming properly. Without collagen, we do not have the osteoid matrix on which the bone can be laid out. So there is no osteoid. In rickets, there was no mineral. In scurvy, there is no osteoid. In addition, because collagen is not formed, you're going to have a lot of bleeding. So the typical history would be bleeding gums. There's bleeding around the hair follicles that leads to this corkscrew appearance of the hair, right? So these would be the history that is given to you. Now, what are the various signs? So on the X-ray of scurvy, there are a lot of named signs that you need to remember. They don't really ask you these directly, but you can be given an X-ray and diagnosis can be tested. Okay, so now have a look at this X-ray. Can you see how the metaphysis is very, very white? This is the Frankel's white line. So this is the Frankel's metaphyseal line. See how smooth it is. If it was healing rickets, it would be pretty irregular. Secondly, the associated sign wherein the epiphysis appears very well defined. You see that there is an outline around the epiphysis which is called as Wimberger rim sign. So there's a rim around the metaphysis, Wimberger rim sign. Now, where you have the white metaphyseal line, just here, you're going to have this lucent zone here. This is called as tremor field zone. So you have the tremor field zone here, which is the zone of lucency just above the Frankel's white line. Fourth sign here is this spurring. There is a triangular spur at the metaphysis which is called as Pelton spurs. So you have Pelton spurs. So there are 4 named signs that you want to remember. Just to recapitulate for you, we have Frankel's white line of epiphysis. You have the tremor field lucent zone which is there. You have Wimberger rim sign which is the epiphysis which is very well outlined. And we have the Pelton spurs. In addition, you can also have subperiosteal hemorrhage. Because collagen is not there, you can also have subperiosteal hemorrhage which can ossify with time. So you can see here how there is periosteal elevation and you have this hematoma here. This subperiosteal hemorrhage is very painful. So the child refuses to walk and that is why it presents as a pseudo paralysis. The parents think that their child is paralyzed, but that's not the case. He's just having a lot of bleeding because of subperiosteal hematoma. Okay, so these are all of the changes that happen in scurvy. Okay, now we talk about the next metabolic bone disease, which is hyperparathyroidism. So here you want to remember that hyperparathyroidism could be primary or secondary. Primary hyperparathyroidism is because of a parathyroid adenoma, wherein you have a tumor in the parathyroid which is producing excess PTH hormone, or you could have secondary hyperparathyroidism which is because of chronic kidney disease. This is also called as renal osteodystrophy. This is called as renal osteodystrophy because it's because of primary renal origin. One thing here very, very frequently asked, PTH adenoma, what is the investigation of choice to localize? The answer is a nuclear medicine scan which I will teach you, which is called SESTA-MEB scan. So right now just have this in your mind. SESTA-MEB scan is the best to localize parathyroid adenoma. Okay. In addition, also remember PTH adenoma. Which syndrome is this associated with? So remember MEN1. We also have parathyroid hyperplasia in men 2A, but parathyroid adenoma per se is associated with men 1. So I'm just going to note down both so that you remember parathyroid pathology per se is in men 1 and men 2A here. Okay, so this is about the basics. Now what happens to the biochemical profile? Calcium, phosphate, PTH, ALP. So we know PTH is rising here. So in primary hyperparathyroidism, this is what the problem is, that too much PTH is getting released. What does PTH do? It's gonna increase the calcium, decrease the phosphate. Like I told you, calcium phosphate run in opposite directions. So what parathyroid does is, it causes a lot of bony resorption. So it leads to bony destruction everywhere so that calcium and phosphate come out into the circulation. Further still, it's gonna now increase the phosphate excretion from the kidney. So calcium in the body overall increases, but the phosphate goes down. And what happens to ALP? It's a marker of bone formation or repair. So anytime PTH increases the destruction, the marker of bone formation also has to increase. So the ALP levels rise here. Okay, so this is the marking of primary hyperparathyroidism. Okay, wherein you have PTH high, calcium high, but phosphate is low, and ALP is also high. So now, because parathyroid hormone is causing diffuse lysis of all of the bones around the body, those are going to be the X-ray changes that we see. So on the skull, this we've already seen in neuroradiography as well. You see that there are these very, very tiny sort of lytic lesions which represent the bony resorption. Okay, so this is called as the salt and pepper sign. So this is the salt and pepper sign, wherein you have this diffuse bony lytic lesions throughout the skull, which are very, very tiny. The pathognomic feature, remember, of primary hyperparathyroidism is the fact that you have some periosteal resorption. So here you can see how in the second and third proximal and the middle phalanges, we are having this sort of a destruction on the radial side. So this is a very, very specific feature that we see in hyperparathyroidism, wherein the radial aspect of which digits? Of second and third proximal as well as middle phalanges show you this irregular subperiosteal resorption. Subperiosteal resorption. Okay, so this is something that is the pathognomic finding here. Okay, so subperiosteal resorption in second and third radial aspect. In addition, here you can have these pseudotumors. There are multifocal lytic lesions in the bones here, which could be appearing, which could mimic a giant cell tumor or an aneurysmal bone cyst. But because of its multiplicity, we can diagnose them. These are brown tumors. Alright, so these are brown tumors pathologically. These are also called as osteitis fibrosa cystica. Because of recurrent hemorrhages here, you can have this appearance wherein they look like a cyst filled with blood, and because of the hemosiderin, we call them brown tumors. Okay. Another finding in hyperparathyroidism is loss of this ligament here. So below the tooth socket, you can see this white line that is called as lamina dura. In hyperparathyroidism, because of resorption, there is loss of lamina dura, which is seen. All right, there's going to be a loss of this ligament that has been marked here in hyper-PTH. So 4 signs of hyper-PTH: salt and pepper, subperiosteal resorption, diffuse multiple brown tumors, and loss of lamina dura. Now let's talk specifically for secondary hyperparathyroidism. We discussed it's also called as renal osteodystrophy. So here the problem is CKD. Anytime you have chronic kidney disease, what happens is the terminal enzyme, that is 1-alpha hydroxylase, which is going to produce active vitamin D3, that is dihydroxy vitamin D, will not be formed. So you have a functional vitamin D deficiency. And in addition, what you have is phosphate retention. The kidneys are unable to excrete the phosphate, so the phosphate levels rise. So effectively, because of vitamin D deficiency, the calcium is low. Because calcium is low, the PTH increases. Hence the term secondary hyperparathyroidism. And most importantly, you want to remember that phosphate here is going to be high because the kidneys can't excrete them, and because PTH is high, ALP is also going to be high here. Okay, so remember this in two concepts. Calcium is low because vitamin D is not forming. That's why PTH is high and that's why ALP is high. But then phosphate here is increased because the kidneys are unable to excrete the phosphate out. Okay, so that is what is very, very important, and the resultant appearance in the spine is going to be called as this rugger jersey spine. Like a rugby player's jersey who has alternate black and white stripes, the vertebra here shows you there are sclerotic end plates and then there is lytic or there is lucency in the central part. So alternating white and black appearance here is likened to the rugger jersey here. Okay, why the sclerosis? So we saw that in primary HPT there's only destruction, there's only lysis which is happening. Why is there sclerosis here? So the reason behind the sclerosis is phosphate. Remember, wherever phosphate retention happens, the phosphate is going to sequester the calcium and it's going to cause this sclerosis here. Okay, so it's actually because of the phosphate retention that we see the rugger jersey spine. Okay, so this is about secondary hyperparathyroidism. Now look at this CT here. So this is the CT of the brain, wherein you can see how the basal ganglia, this is the caudate, this is the putamen or the lentiform nucleus, which is showing calcification. You're having subcortical white matter calcification. So this here, when you have so much calcification, that is soft tissue calcification, particularly involving the basal ganglia, subcortical white matter, you can also have the cerebellum getting involved here, right? So whenever you have so much diffuse calcification, what are the differentials? The most important differential is hypoparathyroidism. I'm not talking about hyper, I'm talking about hypo. Sounds contradictory that in hypo-PTH calcium should be low. Then why is it causing soft tissue calcification? Again, the concept being in hypo-PTH, the calcium is low but the phosphate is high, isn't it? So when the phosphate is high, again it's going to deposit, it's going to sequester any remaining calcium and cause soft tissue calcification. So remember this, soft tissue calcification is more because of more phosphate rather than more calcium. Okay, I hope this concept is clear. So one DD is hypo-PTH. Second could be a differential which is pseudo-hypo-PTH, wherein you don't really have parathyroid being low, but there is end organ resistance. So functionally, it is like a hypo-PTH state. Fine, so that is pseudo-hypo-PTH. Then there is a syndrome called cocaine syndrome, different from the cocaine drug, and there's also a syndrome called Farr's syndrome, which is a neurodegenerative syndrome. Elderly patients will show this. Okay, so these are the various differentials of basal ganglia calcification. Okay, now let's talk about the next disease. Here you would have a child who's presenting to you with pancytopenia, and in addition also has hepatosplenomegaly because of extramedullary hematopoiesis. When you look at the bones are going to be very high in density and they show you this typical bone within bone appearance. So this is called as bone within bone appearance or the sandwich appearance. It looks as if there is one vertebra within the other. It looks as if there is one bone inside the other, right? So this is the bone within bone or the sandwich appearance that is seen in what disease? What am I talking about? We're talking about osteopetrosis. So osteopetrosis is a disorder in which the osteoclasts are defective. Within the osteoclast, the calcium anhydrase 2 enzyme, which is there, which is supposed to make the osteoclast functionally active, is deficient. So because osteoclasts are not working, there is no bony remodeling. There is very, very disorganized bone everywhere, which leads to the obliteration of the bone marrow, and that is why you have bone, first of all, and that is why you have pancytopenia and resultantly hepatosplenomegaly is also seen. So this is osteopetrosis. Remember the bone within bone and the sandwich appearance. Okay. Next, we talk about a disease of the elderly, a metabolic bone disease of the elderly, wherein they would tell you that there is an elderly male patient who comes to you with a biochemical profile wherein calcium is normal, phosphate is normal, PTH is normal, but there is isolated rise in ALP. Fine. So that's the first point, that isolated rise in ALP will be a big clue. Secondly, this is a disease wherein you can have a blastic phase, meaning there could be white sclerotic lesions. There could be a lytic phase wherein there is destruction of the bone, and in the end stage, there's going to be a mixed burnt out stage wherein you have few lytic lesions, you have few blastic lesions. Let's have a look at the appearance here. So in the skull, can you see how there are these white lesions? These are called as cotton wool spots. So this appearance is given the name of cotton wool appearance, wherein you have sclerotic or blastic lesions. Or you can see how there is this large lytic lesion in the skull. This is given the name of osteoporosis circumscripta. So as we have discussed, you can see lytic lesions also in the skull, osteoporosis circumscripta. You can see blastic phase, cotton wool spots, or there could be a mixed phase in the burnt out stage as well. What am I talking about? So we are discussing Paget's disease. So Paget's disease is a disease of the elderly, wherein again the bony remodeling is defective and you have these three phases. One very important appearance here in the mixed or the blastic phase, because the bone is growing so much. One typical history is that an elderly person comes to you with increasing hat size. We never ever hear somebody saying that my hat size or my head is increasing in size after attaining skeletal maturity, right? It's a very, very peculiar manifestation. This has been given the name of Tam O'Shanter sign. So Tam O'Shanter sign is basically increasing hat size history. Apart from that, you can also get history that the foramina, the cranial foramina, are all getting occluded because of the bony hypertrophy. So here you can have the 8th cranial nerve getting compressed, you can have the 2nd cranial nerve getting compressed, resulting in optic atrophy, or you can have hearing loss. So you can get history of hearing or vision loss because of optic nerve or auditory nerve getting compressed. Alright, so you can have cranial neuropathies here. Okay, so we're talking about Paget's. What about the other bones? So it's a multisystemic disorder. So within the long bones, you can also have lysis or sclerosis. So when the lytic phase, you can have this white line, which is this advancing edge of lysis progressing along the long bones. This is called as blade of grass appearance. So this is the blade of grass sign that is seen in the long bone lysis. In the vertebra, you can see how you have this peripheral sclerosis and the center here is lysed. So this is given the name of picture frame vertebra. So you have this picture frame vertebra, which is mixed blastic and lytic phase in Paget's disease. Again, one more appearance here wherein the complete vertebra is appearing very, very blastic, very, very sclerotic, is called ivory vertebra. So ivory vertebra, what are the different differential diagnoses? One condition that we are just discussing, that is Paget's. So in the blastic phase of Paget's, you can have ivory vertebra. Apart from that, when you have blastic metastasis. So blastic metastasis, remember 3 main primaries only which give blastic metastasis. One, prostate CA, extremely important. Second, breast CA in females, can give you blastic and lytic metastasis. Lastly, you can remember carcinoid. So carcinoid metastasis can also be blastic, but what's most important is breast and prostate that you want to remember. Any other differentials? You want to consider Hodgkin's lymphoma as well, can give you this ivory vertebra appearance. Okay, so this is about ivory vertebra. Next, we want to discuss a pathology, very, very important for the exam, wherein you have this diffuse loss of bone mineral density. So when overall bone mineral density is reduced, we call this osteoporosis. So osteoporosis is this generalized reduction in bone mineral density. When I do the biochemical profile, calcium, phosphate, PTH, LP, everything is going to be normal, right? So this is something very useful and very easy to remember. So everything is going to be normal. Then what can we do? We can do an X-ray. Usually the females would be postmenopausal females here who are presenting of low backache, because spine is one of the most common areas to be affected. You do the X-ray and what you observe is that all of the bones are very weak. They are all deforming by the axial load, and this shape here is called as codfish or codfish mouth vertebra. So codfish vertebrae here, wherein they are deformed because of the axial loading. In rare cases, you can also have a compression fracture. Because of the axial load, these fractures can happen wherein the spine or the vertebra is compressed. So we can have codfish vertebrae or compression fractures here. What is the investigation of choice? You want to remember, it is DEXA scan. So the investigation of choice for osteoporosis is dual energy X-ray absorptiometry. DEXA stands for dual energy X-ray absorptiometry. Okay, so DEXA is the investigation of choice. Herein, what you do is you compare the bone mineral density of your patient with that of a young adult. You can do that with an age-matched, sex-matched patient as well who is normal, or you could do that with a young adult. So two kind of scores are there. If you are matching it with a young adult, it is called as a T-score. If you are comparing the bone mineral density with age-matched individual who is normal, we call it Z-score. Alright, so how you can remember is young adults wear t-shirts. Yeah, so T-score is for young adult comparison. Okay, herein what we do is after the comparison we give a standard deviation score. So this score, if it is less than minus 2.5 standard deviation, that is the definition of osteoporosis. So as you can see, from minus 2.5 standard, so here you can see how we have compared the density in normal osteopenic and osteoporotic patients. Alright, so when the score is minus 1 to minus 2.5 standard deviation, that is defined as osteopenia, and anything more than minus 1 standard deviation is normal. Okay, so this is normal. Minus 1 to minus 2.5 is osteopenia, and less than minus 2.5 is osteoporosis. One recent advance, nowadays we also do quantitative CT and ultrasound for osteoporosis. This gives us a 3D estimate of the entire volume here. If you see in DEXA, we are only doing a two-dimensional estimate. So it's either from the femoral neck or it's in the spine that we compare the bone mineral density. But in a quantitative CT or ultrasound, it's the entire volume of the bone which is considered. So it's now going to be the future of this osteoporosis estimation, but not very frequently tested. This is a repeat AIMS question. Remember, quantitative CT and ultrasound are also used. This is a recent advance that we want to remember. Okay, so this is osteoporosis in a nutshell. BMD reduction, codfish vertebrae, all biochemical profile normal, DEXA scan, T-score less than minus 2.5 SD, and recent advances quantitative CT and ultrasound. Okay. Next, we talk about another endocrine pathology, which is acromegaly. Acromegaly, as you know, is an increase in the growth hormone which occurs after the skeletal maturity. So the height does not increase, that is gigantism. Herein, we are going to have increase in the soft tissue. So what kind of changes are going to be seen? Look at the phalanx. There is outgrowth of the phalanx here. It looks like a spade. So this is called as the spade phalanx in acromegaly. Something very typical. You will not hear this anywhere else. When you see that there is heel pad thickness increasing, you can see the soft tissue here. So this is increased heel pad thickness. It's so unique that if you hear this, you can just mark acromegaly. The objective criteria is anything more than 25 mm in soft tissue is increased heel pad thickness. What about the skull? So again, in the skull bone, what you're going to see is that there is increased jaw angle, which is called as prognathism. You would see that the sinuses, the maxillary sinus here, all of the other sinuses are going to proliferate. So there's going to be increase in the size of the paranasal sinuses. You would have the calvarial thickening, the bony calvarium increasing in size. So calvarial thickening is seen, sinus hypertrophy, prognathism. These are all of the changes of acromegaly. Remember, the screening test for acromegaly is IGF-1. IGF-1 is the screening test, and confirmatory test here for acromegaly is going to be an oral glucose tolerance test. When I give glucose to a normal person, GH gets suppressed. But here, there is no suppression of growth hormone. Alright, so remember in endocrine, the general principle, the screening and confirmatory tests are always going to be biochemical, alright, whereas the localizing investigations are going to be radiological. Okay, so this is about acromegaly. Next, we have a child who's presenting to us with multisystemic involvement. So there's a patient who's a child who's having multifocal skin lesions, can have liver involvement, and can have multifocal bony lytic lesions. What kind of lytic lesions? So in the skull, you can see how there are these large geographical lytic lesions, and you will see that there are double margins. So in the skull, geographical lytic lesions with a beveled margin, that is something that we would see in LCH. In addition, in the spine, you can see how the complete vertebra is destroyed. This is called as vertebra plana. Complete flat plain vertebra plana. In the mandible, you can see how there are so many multifocal lytic lesions. It looks as if the teeth are floating. This is called as floating teeth sign. So these are three appearances that we have as far as LCH is concerned. So what we are discussing is LCH, Langerhans cell histiocytosis. So this is a malignancy here wherein you have these multifocal deposition of the histiocytes. Remember, multifocal bony lytic lesions is what we are going to be seeing here in a child. What is the pathognomic feature? So pathologically, you will see electron microscopy shows you these tennis racket bodies, which are called as Burbeck granules. The CD markers here are important. So Burbeck granules has this Langerin protein, which is CD207. You can also have S100 and CD1A positivity. So the markers here are important: S100, CD1A and CD207 for LCH. Okay. Now going ahead into next pathology, what do you see in this X-ray? One, the bone density is increased, and secondly, there is this ossification of the interosseous membrane, right? So whenever you have increased bone density, and the hallmark here, very unique here, is the interosseous membrane calcification. The diagnosis that you want to consider is fluorosis. So this is skeletal fluorosis that you have when the fluoride intake in the water is increased. So remember, we can have dental fluorosis to start with, wherein the teeth are very sclerosis. It happens when the fluoride level is more than 1.5 to ppms. It could be skeletal fluorosis when the levels are even higher at more than 3 parts per million. So this is what you want to remember about fluorosis, interosseous ligament calcification. Next, we talk about a pediatric pathology wherein you are going to have a triad of a short neck. You would have a hairline which is higher, and you would have fused cervical vertebrae. So multiple fused cervical vertebrae. What am I talking about? We're talking about Klippel-Feil syndrome. So Klippel-Feil syndrome, remember, we're going to have multiple fusions. C2, C3, C3, C4 are getting fused and forming these block vertebrae. Block vertebrae are these fused vertebrae, and that results in a shortened neck. The syndrome is Klippel-Feil syndrome. Another association, in fact, this is associated with Klippel field as well, where you have the scapula which is higher. Can you see how the scapula is higher? And you also have this bony bar connecting it to the vertebra. So this pathology is called Sprengel's deformity. Clinically, it would look like winging of scapula to a certain extent. So a clinical image would be given to you. Sprengel's deformity is a high riding scapula. And here you frequently have this bony bar which is called as the omovertebral bar. So there's a bar connecting the vertebra here, omovertebral bar. This is the Sprengel's deformity. Okay. So these are two associations of the pediatric pathology of the spine of the cervical vertebrae. Alright, so this is about that. So now discussing a few important skeletal dysplasias. The first condition that we want to discuss here is achondroplasia. In achondroplasia, there is a defect in the enchondral ossification of the bones, resulting in short limb dwarfism. Alright, so what kind of dwarfism you have is limbs are shorter, trunk is okay, and even within the limbs, it's the proximal limbs which are going to be shorter, as in the proximal arm and the thighs are going to be shorter with respect to the distal part of the limbs. Alright, so this type of deformity is called as rhizomelic shortening. So here you're going to have rhizomelic shortening in achondroplasia. There's a defect with the enchondral ossification of the bones. What are the different signs that we're going to see? So in the hand, you're going to have this trident hand deformity, increased distance between the two digits. This is called as trident hand. In the limb X-ray, you can see how the femur here are so short. So this is rhizomelic shortening, and at the metaphysis, there is this V here which gets formed. This is called as chevron sign. So remember, in achondroplasia, it's the metaphysis which is affected. There's this V which is the chevron sign. When you look at the pelvic X-ray, look at the iliac blades. The iliac blades are flattened here and widened like a tombstone. So this is called as tombstone appearance of the iliac blades, and the pelvic inlet here tends to look like a champagne glass. So that is the champagne glass appearance that is seen here. So tombstone sign, champagne glass sign, and when you look at the vertebra, look at the posterior margin. There is this posterior scalloping here which is called as the bullet sign. Alright, so they start to appear like bullets. This is called as posterior scalloping. Okay, so these are all of the findings in achondroplasia. Trident hand, chevron sign, tombstone, iliac blades, champagne glass pelvic inlet, and bullet appearance of the vertebra. The next skeletal dysplasia we want to discuss is MPS, that is mucopolysaccharidosis, which is a lysosomal storage disease. So in MPS, mucopolysaccharidosis, what are the findings that you're going to see? So mucopolysaccharidosis is what we're going to be discussing. So in the skull, look at the sella here. The sella appears like a J. So this is called as a J-shaped sella. A J-shaped sella is something which is not really specific to this. It can be a normal variant as well. It could be seen in an optic glioma. Alright, so it's not really specific, but it's also one of the findings of MPS. Look at the ribs here. The ribs appear very, very widened. The shaft of the ribs is very much widened like oars of the boats. So these are called as oar-shaped ribs. Alright, so that's one, widened ribs, oar-shaped ribs. And look at the metacarpals. There is proximal tapering of the metacarpals that make it look like bullet. So this is bullet-shaped metacarpals. Where did we study bullet-shaped vertebra? We just saw that in achondroplasia. Another thing that you want to remember is hook-like metacarpals. Where do we see hook-like metacarpals? That is in hemochromatosis. So remember hemochromatosis. In this topic itself, we have discussed that hemochromatosis is one of the associations of pseudo-gout, right? 1 hour back we were discussing this. So that's one more thing for you to remember. Hook-like metacarpals are going to be seen in hemochromatosis. Alright. Apart from this, in the spine, what we are going to have is this wedging of the vertebra. So when you have these wedges or these projections which is in the inferior aspect of the vertebra, so this is antero-inferior wedging or beaking of the vertebra, antero-inferior beaking, this is more commonly associated with Hurler's syndrome. On the other hand, where you have this central tongue-like projection, you have a central beaking. Central beaking is more common with the Morque's type of MPS. Alright, so remember overall, all of the skeletal changes that we have discussed so far, J-shaped sella, O-shaped ribs, bullet metacarpals, all of the skeletal manifestations are far more common in the Morque's variant of MPS, okay? But antero-inferior beaking is one thing with Hurler's, alright? Next, we want to discuss three pathologies here. So these are three vertebra. These are three skeletal appearances which make you feel that something's really wrong with this person's bone. But actually, the common thing to all three of them is they're going to have no effect on the overall bony development. These are just dysplasias which give rise to a very scary looking appearance. But overall, you just have to reassure the patient that nothing's going to happen to them. Okay. So in the first one, you can see how there are these white dots, sclerotic dots within the patient's bones. This is called as osteopoikilosis. Again, you just got to reassure. When you have these lines here, that is osteopathia striata. This is called osteopathia striata. And when you have this candle wax dripping sort of sclerosis here throughout the bone, this is called as meloriostosis. So this is meloriostosis. So these are three skeletal dysplasias with scary appearance and scary names, but nothing is scary about them. Alright, so osteopoikilosis, osteopathia striata, meloriostosis, you just ask your patients to be reassured. Alright. Next, I want to discuss one very important approach wherein they'll give you the history that the patient, which is typically a child, has had recurrent fractures, alright. So when you have multiple fractures in different bones, there are two possibilities. One, the more ominous possibility here is non-accidental injury, that is child abuse, or the other possibility, which is a repeat question, is osteogenesis imperfecta, wherein you have a collagen 1 deficiency because of which the bones are not properly formed, right? So we have collagen 1 in bone, you want to remember, 1 for bone, O-N-E, and tendon, O-N, add an E. So bone and tendon have collagen 1. Fine. So remember, osteogenesis imperfecta will also have multiple bone fractures of different ages. Here, you are going to have these diaphyseal fractures more commonly, and that's going to heal with a lot of callus. So the property here is these are diaphyseal in nature and there is exuberant callus formation. On the other hand, when we talk about non-accidental injury, the morphology of these fractures are metaphyseal triangular fractures. These are called as bucket handle fractures. So you have bucket handle fracture here, which is a metaphyseal triangular fracture. Okay, so this is how you can actually differentiate the two pathologies, wherein you'll have a similar picture of multiple healing fractures of different ages, right? So different ages fractures is what prompts you into distinguishing these two. Now going ahead and discussing the next important condition which has had a lot of questions in the recent years is AVN. So AVN, which is avascular necrosis, frequently involves the hip joint. Hip joint is the most common joint to be involved. Here you would have risk factors such as alcohol abuse. They can give you that the patient is on steroids, the patient has sickle cell anemia, or could be associated with a decompression sickness, right? So such history would be given to you. Most frequently it is the use of steroids which is implicated, and the X-ray is going to show you this sclerosis and lysis which gives rise to this crescent here. So there is mixed lysis sclerosis which gives rise to this crescent sign. So X-ray is frequently shown here. So this is avascular necrosis. On a bone scan, you're going to have increased uptake. So increased circular uptake makes it look like a donut. So this is a donut sign. And what is the investigation of choice for avascular necrosis? It's the MRI. So the earliest change, like we have discussed, is going to be bone marrow edema. So bone marrow edema is going to be seen, followed by the necrosis. So you are going to have this necrosis on the superior aspect of the femoral head, and eventually if it progresses untreated, you're going to have complete collapse. So the entire femoral head can collapse. Okay. So early stages, you will have bone marrow edema. Followed by that, you have this necrosis here, and in the end stage, you're going to have this complete collapse of the femoral head. Okay, so this is avascular necrosis of the hip. The next pathology we want to discuss is chronic osteomyelitis. So in this X-ray, you can see chronic osteomyelitis. You'll have history of chronic inflammation, discharging sinus from a limb. The X-ray is usually asked to be marked. So here there are three main appearances you want to be aware of. This central part here marked by the yellow arrow is sclerotic. It's white, and S for sclerotic, S for sequestrum. So the central part here is called as the sequestrum. So sequestrum, remember, is the central sclerotic part here, which represents the dead bone. So because it is dead bone, there is no devascularization that is happening, and that would result in this white mineralized bone. Surrounding the sequestrum, we have this lucent zone here, which is called as involucrum. So involucrum is the surrounding lucent area here, which represents granulation tissue. So this is reparative granulation tissue which is seen around the central white sequestrum. Here you can see how there is an area from which the pus is coming out. So you can see how the pus is coming out, and this area here is called the cloaca. So the point where the bone gives way and you have discharging sinus is called as the cloaca, which is the defect, and there you will have a discharging sinus. So they frequently ask you to name the parts on the X-ray. So in chronic osteomyelitis, we have sequestrum, involucrum, and we have the cloaca here. Okay, so this is chronic osteomyelitis. The pathology here is a lateral curvature of the spine. So there's a lateral curvature of the spine. This is called as scoliosis. So a lateral deviation of spine is scoliosis, and the angle that we measure for scoliosis is Cobb's angle, right? So this is the Cobb's angle for scoliosis. Any Cobb's angle more than 10 degree is what is defined as true scoliosis. Here you also want to remember a screening test that is done, which is called as Adams forward bending test. So you ask the person who's frequently a child to bend forward. So Adams forward bending test. If the scoliosis or the lateral curvature persists, it's a true structural scoliosis. If it resolves, it's just postural. Alright, so this is a test that is used to distinguish a postural versus a structural scoliosis. Within the structural scoliosis, remember the most common age group to be affected is adolescents. So more common in females. Adolescent females usually have structural scoliosis, which is idiopathic in nature, meaning there is no cause. A lot of times this could be associated with congenital anomalies, right? So there could be a congenital hemivertebrae, which could be there. There could be a butterfly vertebrae, which are two hemivertebrae. So these anomalies which lead to scoliosis is the congenital type of scoliosis, and this is a repeat question. All right, so most common is idiopathic. You know this throughout medicine, most common is usually idiopathic, right? So most common is idiopathic, but this question was asked that if there is a vertebral anomaly, what's this called? It's called congenital scoliosis. Okay, so the most frequent question is this image, and they ask you the angle. So remember, this is Cobb's angle. Alright, so this marks the end of the vast chapter of musculoskeletal radiology. A lot of overlap which you must have studied in medicine, peds or orthopedics in general, but a good way to bring everything together. So let's discuss what we had learned. So first we started off with bone tumors. The main approach is going to be based on location and age. So whenever we have an epiphyseal tumor, we remember ECG. So a small child with a small tumor, chondroblastoma, distal end of radius, soap bubble appearance, 30 to 50 years of age. Remember, giant cell tumor, diaphysis, vowels stick together. So if it's an aggressive tumor, large mass mimicking inflammation. Remember, Ewing sarcoma. If it is a very small mass with nocturnal pain relieved on taking NSAIDs, we remember osteoid osteoma, and tibia eccentric mass is adamantinoma. In the metaphysis, remember osteosarcoma, aggressive mass, sunburst reaction, Codman's triangle. We also remember two cysts, that is SBC and ABC. SBC had a fallen leaf sign, whereas aneurysmal bone cyst had a soap bubble sort of an appearance. Other tumors that we studied were exostosis or osteochondroma. Remember, MRI is the investigation of choice to know the cartilage cap thickness. If more than 1.5 centimeter, that's an indication for surgery. In the hand, whenever they show you hand x-ray, remember enchondroma. We talked about Ollier syndrome and Maffucci syndrome. And when we talk about fibrous dysplasia in the femur, you can have a Shepherd Crook deformity. It could be a polyostotic fibrous dysplasia. And I also talked to you about McCune-Albright syndrome with precocious puberty and Maza-Brown syndrome with myxomas. Right? So this is about the bone tumors in the spine. Remember, hemangioma here. Okay? Then we talked about arthritis. So this was acute versus chronic. In an acute monoarticular setting, remember gout versus pseudogout. Gout is going to be monosodium urate negatively birefringent needle-shaped crystals affecting the first metatarsophalangeal joint, causing these large rat bite erosions. Pseudogout, on the other hand, is in the knee joint where you have meniscal calcification or chondrocalcinosis because of calcium pyrophosphate deposition, and that was positively birefringent with the rhomboid shaped crystals. Okay. In chronic arthritis, we divided it further into inflammatory versus non-inflammatory. In inflammatory arthropathy, prototype symmetrical joint space reduction with marginal erosions and with osteopenia is RA. Most common joint is metacarpophalangeal, and what is spared here is the DIP. What is spared here becomes the most common in psoriatic arthropathy, isn't it? So DIP is the most common in psoriatic arthropathy. Amidst the non-inflammatory arthritis, remember large joints, osteoarthritis. Then if there is no pain but looks bad, neuropathic arthritis. If it's a child with recurrent hematomas, remember hemophilic arthropathy. Then we went on to metabolic bone diseases. So rickets versus scurvy is very, very important. Rickets is metaphyseal, cupping, splaying and fraying, whereas scurvy is a whole bunch of named signs with a smooth white line of Frankel, Weinberger's ring sign, Trommerfield zone and Pelkin spurs. Then we also talked about other bone diseases such as hyperparathyroidism. So we had salt and pepper, subperiosteal resorption of the phalanges that we saw, and also the loss of lamina dura. In secondary HPT, what you had was also the Rugger-Jersey spine. Alright, then we discussed Paget's disease being important. So it can have lytic, blastic or a mixed phase. So in the skull, you have cotton wool skull or osteoporosis circumscripta. You can have a picture frame vertebra showing you both of the changes, right? So that's Paget's disease for you. Also remember, osteoporosis is very, very important. So you will have DEXA being the investigation of choice here. Finally, you want to remember that Cobb's angle is what is used for scoliosis. Okay, so this is what is a brief summary of musculoskeletal radiology. The must-know images that are a takeaway from this, the angle, this is the Cobb's angle that is being measured in a case of scoliosis, right? So this is Cobb's angle being measured in scoliosis. In this case, there is a metaphyseal bone tumor, white because it's bone forming. You can see the Codman's triangle, and this is the sunburst reaction that is seen in osteosarcoma. sarcoma. So this is osteosarcoma here. In this X-ray, you can see how the bones are all bent here. So this is the codfish vertebrae in osteoporosis. Investigation of choice is DEXA. In DEXA, we take the T-score for WHO grading. The T-score minus 2.5 standard deviation is osteoporosis. Very, very important. Spondyloarthropathy, wherein you have a young male with backache and you see how there is complete fusion with this dagger sign here. So this is ankylosing spondylitis. Before the spine changes happen, remember the earliest manifestation here is going to be sacroiliitis. That is going to be picked up on MRI, which is the investigation of choice. Very, very important, tumor, distal end of radius, epiphysis, fused skeletal plate, meaning an older patient. This is GCT or osteoclastoma. And finally, here the distal end of radius and ulna of this child is irregular with metaphyseal cupping and splaying. So this is rickets. Right, so 6 images, very, very important: scoliosis, osteosarcoma, osteoporosis, angspond, GCT and rickets. Okay, so this is our takeaway from musculoskeletal radiology. Let's quickly discuss the previous year questions. The first question here, a 35-year-old male with pain and swelling around wrist joint. So this is something that we have seen here. So this is giant cell tumor, distal end radius, age is fitting, matrix is fitting. So this is GCT. It's not osteosarcoma or rickets or a fracture. Identify the diagnosis. Hand bones. Anytime you see multifocal hand bones being involved by tumor, these are hand for N. So this is multiple N chondromas. These are not overgrowths. These are not brown tumors or fibrous dysplasia. Identify the structure, mark with the yellow arrow. So here what you see is the sclerotic part here. So white sclerotic is the sequestrum, which is the dead bone, and that is why it appears whiter. The lucency surrounding it is the involucrum and the defect is cloaca. This is not an osteoid osteoma. All of the following are useful in osteoporosis. So DEXA indeed is the investigation of choice. Quantitative CT is also recent advance. Bone scan has no role. We'll discuss this in nuclear medicine when we go to bone scan. But bone scan really has no role in osteoporosis. But chemical analysis is very frequently done because you want to distinguish the other metabolic bone disorders. So the correct answer would be 1, 2 and 4. That is option C. So this is a repeat AIMS question which does give you, questions like these where multiple options are correct, So this is something which is very important. A 40-year-old male with progressive forward bending and increasing stiffness of the spine, CT was shown. So look at the CT here, which is showing you a complete fusion, deformity with calcification of interspinous ligament. So this has to be angspond. A fluorosis image is going to show you increased density without this fusion. You can also be given the interosseous membrane ossification, but not this. It's not Reiter's and it's not rheumatoid. Rheumatoid, remember, would be atlantoaxial dislocation, not the entire spine, okay? 26-year-old male with backache, morning stiffness and reddening, X-rays shown. So again, you will see how many questions from angspond have come in the past. You can see how this complete fusion with the dagger sign. So this is ankylosing spondylitis. 70-year-old male with a history of painful limb, no drug intake or trauma, most likely diagnosis. So this is kind of a difficult question, but if you look carefully, you can see that there is lytic sclerosis. This is the crescent sign of AVN. How to crack this question even if you don't know? It's a difficult question because they have given really no history that would point to it. How is it not TB? So remember, TB is a pathology which is an inflammatory pathology. So you are going to have joint distension here. Or you could also have erosions which are present, which is not there. In the later stages, there would be complete destruction of the femoral head that would sit into the acetabulum, and this is called as the mortar and pestle appearance. So none of these changes are seen. Angstpond will not affect the hip joint, it would affect the SI joints, and 70 years is really not the age for this. And RA again will not involve the hip joint. So it's between AVN and TB hip, and when you don't really see a typical mortar pestle appearance, it's always wiser to go for AVN because it has very high odds of being asked, So this is something which is very important for the exam. So when you're stuck, just rule out options, get to a 50-50 odds and then go for the more commoner thing or go for the thing which is more likely based on the past, So you have to use everything that you have in order to answer the question. Try to recall any information that you have and be very smart about attempting the questions. Okay, so that is how you can crack the MCQs. Biopsy of the spine is indicated in all except suspected drug resistance is an indication. Cold abscess without neurological involvement is no indication for biopsy. Remember, in TB, if there is cold abscess, no neurological involvement, the first line is start ATT. Radiological evidence is enough to start ATT, biopsy is not indicated. But if there is neurological involvement or diagnostic uncertainty, biopsy is indicated. Okay. Prenatal ultrasound in a 35-year-old female showed a fetus with multiple fractures. So this is a very severe type of osteogenesis imperfecta, which is type 2, wherein you can have in utero multiple fractures. It will not be seen in achondroplasia, Marfan's or cretinism. Okay. A 10-year-old child with normal bone mineral density, X-ray here is showing you this white metaphyseal line with this very, very well-defined epiphysis. So this is likely to be scurvy. Okay, so Frankel's line, Wimberger's line, this cannot be rickets because bone mineral density is normal. Osteopetrosis will also have a high mineral density, and metaphyseal dysplasia can also show you this irregularity here in the metaphysis. But frequently it would be all of the bones getting involved, and you would also have epiphysis being normal in that case. Okay, so the better answer here is scurvy. A 5-year-old boy is having an inability to pronate and supinate. What you are seeing here is the radius and ulna getting fused, right? So this is the radius and this is the ulna, and there's a bony bar, not something that you would see routinely. So this is radio-ulnar synostosis. It's a repeat FMG question wherein you have this fusion of the radius and ulna here, radio-ulnar synostosis. There is no fracture that is seen in this case. 56-year-old male with bilateral hearing loss. X-ray is shown, so you can see how on the skull X-ray there is this diffuse expansion with multiple sclerotic spots. This is called as cotton wool skull appearance, and the diagnosis here is Paget's disease. Okay, so this is Paget's, which is cotton wool skull, and this is also the history which helps us because of the bony expansion. There is compression of the auditory nerves. Okay. A 20-year-old patient with chronic low backache and early morning stiffness associated with bilateral heel pains. So this is enthesitis, young male. So angstpond again. This is ankylosing spondylitis. Name of the angle, you can see this is the Cobb's angle. Remember that the Bohler's and the Gissane angle are used in calcaneal fracture. Alright, so these are two angles that you're going to hear in calcaneum fracture. Remember, Bohler lowers whereas Gissane increases. So the trick here is Bohler lowers. Kite's angle is what is important, which is used in CTV. Alright, so this is used in CTV is what you want to remember. A 65-year-old female with low backache, what is the likely diagnosis? So you can see that there is a reduction in bone mineral density and one vertebra is compressed. So this is osteoporosis with a compression fracture. Don't be in a hurry and mark this osteopetrosis by reading incompletely. A lot of time we read the first word, overconfidently you mark out the wrong option. Okay, so read carefully. Questions which you know should not be wrong. Alright, so you have to be very careful in eliminating everything and then confirming that it is indeed correct. Okay. 50-year-old male patient presenting with diffuse backache, C-spine X-ray shown. What you could see here is an elderly patient with ossification along the ALL. This is not angstpond, this is dish. The entire fusion is not there. It's just the flowing ossification along ALL. So the diagnosis is going to be dish here. 10-year-old girl presents to the OPD with a back deformity. So you can see a scoliosis and you can also see how there is hemivertebra associated. So this is a congenital form of scoliosis where you have hemivertebra. Alright, so this is something we discussed, a hemivertebra. This is scoliosis without any causes idiopathic. If you would have seen neurogenic tumors, that's NF1. Other associated neuromuscular pathologies is the neuromuscular type. A patient presents with persistent backache, past history of pulmonary TB. What is the diagnosis? So this is a coronal MR wherein you can see this is the two psoas muscles, and within the right psoas there are these fluid containing lesions, which is the abscess. So this is psoas abscess. Even if you don't know this, just rule out. It can't be inguinal hernia. Perthes disease is a disease which affects the proximal femoral epiphysis. So proximal femur is not shown here. Uretrocele is an adder head appearance which is seen on IVP, which is not seen here, right? So you can just rule out and also reach the diagnosis very easily in such questions, okay? So that's it as far as MSK radiology is concerned. Thank you so much. I'll see you all in the next one.